right? And the limitations of diagnostic tools are something that you can only identify with actual practice on actual patients. And the LARPing that we end up doing in our community with all this notional stuff actually is not super helpful, except maybe just for equipment familiarization. And it's a totally different mindset that we need to get into post GWAT. And you're absolutely right. I was just helping some great dudes do some fantastic training. And it's really hard, even intentionally, when people are talking PFC, to actually get into that reoccurring, reassessing mindset, and starting to take nursing care seriously, which is what we all need to do. And, trying to manage drips, mix up medications, work on all the other stuff that's going to be involved with managing critically ill patients for prolonged evacuation horizons. We all know what that looks like, but actually trying to flex it or figure out how to mix up all that stuff, it's really hard. When I work in the ICU, there are specialty trained subject matter experts who've gone to school for years to do all that sort of stuff. And do you know who that isn't? Yeah, I have no idea how to do all that. There are ICU nurses that are much, much better. And so asking all of our guys who are not ICU nurses, who are not trauma surgeons, to basically do that equivalent, one, I wonder how valid it actually is. But two, you can't get good at that by going to a refresher once every 2 years and then just reading a couple articles, especially articles like this that if you have the time to deep dive, don't actually tell you that.
Yep, absolutely.
And I can't remember the podcast that Minla Kong did. He was a fantastic retrieval doctor out of Australia, and they'd fly their twin engine planes thousands of kilometers. But he really ultrasound assessment for trauma patients over the hours that it took for him to evacuate patients, and I can't remember the acronym. Because everything's got to have a snappy acronym. But instead of the FAST, he ended up doing the slow, and it was just going back again and again and again, doing ultrasounds. And over time, you could develop and see differences, to your point. And I thought that was so great because, again, when I used to work in the ER, you do a FAST, and then there was either disease or you were waiting for disease to present. But then you just call somebody else and move on. Yeah.
Yeah. So as far as determining, does he need to be transferred out or not? I think that's the chink in the armor that's going to cause people to transfer patients that don't need it or not transfer patients who actually do. Right.
And again, to foot stomp, you only get good at this by actually doing this. So I'm pretty sure it was Manny River. He's the guy who basically came up with the sepsis bundles about 15 years ago. And he is a really, really good critical care doctor. And it turns out, unfortunately, based on some pretty bad data, that a lot of the stuff that he initially recommended for sepsis bundles was garbage. But the way that they created that study is that you either got standard care when you were identified as a sepsis patient in the ER, which meant no shade, but just an ER doctor was taking care of a critically ill septic patient. Or if you were part of the intervention criteria, the Dr. Manny Rivers and his entire team of fellows and residents would come down and sit next to you at the bedside. And those patients got better outcomes. And it had very, very little to do with what they thought was a sepsis bundle. And it was more just the fact that a world-renowned ICU doctor and his entire team of fellows and residents were sitting next to you at the bedside. And that's how you get better outcomes, is by having, I don't want to say better people. That's a value judgment, but people who are better at their job sitting next to you at the bedside. And, he even, I'm pretty sure it's him, he's got a test where he'll just walk up to you, the patient who's getting resuscitated, and touch their toe. And his point is, if your toe is warm, you're probably pretty well perfused. And it's those kind of tricks that you only get by doing this day in and day out, managing actual.
I mean, you're 100%. I don't think it's a trick. It's just, this is what the body does, right? have you mastered your art enough that you can zoom out and look at the whole picture? Or are you busy looking at,